When dealing with knee injuries, and especially in the outpatient environment, it's not uncommon to get asked the question of, do I need imaging or would I benefit from imaging? And there is a lot of different routes that you can go with this. And a lot of it's going to be dependent on, are we dealing with potentially a bony or an arthritic injury? Are we dealing with a potential meniscus or ligamentous injury? Is this more intra-articular or extra-articular? There's a whole separate side conversation that you could go down with all of those different individuals as to if imaging is needed, how beneficial will it be, and given their own specific case and context, really all the details associated with what that conversation should and needs to look like. But if we're talking about traumatic knee injuries and somebody's coming into your clinic, direct access, and you're trying to figure out, should I get imaging? Should I not get imaging? Should I just continue to treat them? Some easy considerations to think of are mechanism of injury, pain profile, and functional status. And when we talk about the mechanism of injury, we want to think of, is this something that happened immediately with an acute specific onset? Was there trauma? Was there contact? Was there impact? Or if it was non-impact or non-contact, was there an audible click or pop or sensation of something giving way, such as in a moment of instability? All of those things are going to provide much more sense of urgency than somebody describing a slow, gradual, non-specific onset with their pain and with their symptoms. Second, when we talk about symptom profile, the intensity of the symptoms, how predictable, and the type of patterning that they bring on with regards to what provokes them and what alleviates them is going to be very important as well. Obviously, with a higher symptom profile, that's going to limit their tolerance and their ability to do things in the clinic in a productive manner. So if we have somebody with a very high symptom profile, it's relatively unpredictable or sporadic, that's going to lead me to wanting to get some more clear-cut answers as to what's going on. If it follows a very mechanical pattern and a very consistent pattern, meaning, yes, they may have high symptom profile and elevated symptom status, but we know exactly what brings it on, we know exactly how to avoid it, and it follows with a pattern that's either very muscular or meniscal or ligamentous or bony in nature, then you're going to need to combine not only this category, but with some of your other categories in regards to functional status and the mechanism of injury to figure out, is this something that we need to act on urgently, or can we slow play it a little bit? With regards to functional status, an inability to bear weight is something that I just immediately recommend that it would be in their best interest to go get imaging, rule out a fracture, rule out bony injury, and also just make sure that what we're dealing with is something that we can actually bear weight on, because that's going to influence our decision making with regards to ADLs, ambulation, work status, and really the bulk of what we would do from an intervention and therapeutic activity standpoint in the clinic. When we're looking at range of motion, I also want to see, do they have clean range of motion, or is there a mechanical blockage, a definitive block in range of motion with this individual? Maybe we cannot fully extend, we cannot fully bend the knee, or somewhere along that path there's a definitive disruption to how that joint and tissue is articulating. That's going to be something in my mind that may warrant a little bit further investigation with imaging, assuming that those three things aren't just being dictated by pain or swelling that you would expect to be there. And then the other one would be bouts of instability. So whether it's patellofemoral instability and we're dealing with the patella that does not want to necessarily stay in place and it's either subluxing or dislocating, we need to get some imaging done just to see the severity of what's going on and what our likelihood of non-surgical success is going to be with this individual. Or if they're just having bouts of the knee giving way with ADLs, activity, or work-related status. And we need to just figure out, is this something structurally that is missing, or is that a deficit? Or is that sensation of giving way less mechanical in nature? and it has more to do with just their pain profile, fear avoidance, elevated symptoms, something along those lines. So with different injuries, you are going to have some rules that are a little bit more cut and dry. With the foot and ankle, we have the Ottawa ankle rules. That's a very clear-cut algorithm as to if they should or should not get imaging. When you are dealing with something that does not have either clinical prediction rules or guidelines or protocols, a good rule of thumb is to figure out what was the mechanism of injury, and is that suspicious? What is their symptom profile? How elevated is it? How sporadic or consistent is it? And really how predictable it is? And does that match up with their mechanism of injury from an expectation standpoint? And then what's their functional status? Are they able to carry out activities of daily living? Are they able to participate in work? Are they able to participate in leisure activities? And how disruptive is that to their daily and weekly schedule, to their tolerance, to their quality of life? And with all three of those things, you're really weighting just how significant each one of those categories is. And obviously, the more the categories are involved, lack of functional status, high pain profile, suspicious mechanism of injury, that's hedging you more towards the side of imaging. If they have a non-suspicious mechanism of injury, they have low symptom profile, and they have a relatively high functional status, the need for imaging is obviously less in that situation. Most are going to fall somewhere along that continuum, but being cognizant of just what both of those anchors look like and how far you're skewed one way or the other can allow you to communicate what's best and what's most appropriate.